Okay, so starting with rheumatology, first I will take up rheumatoid arthritis. So in rheumatology, this thing is important that whenever, like suppose the patient comes to you with hip pain, or the patient comes to you with the knee pain, okay? So you will examine the joint. Patient comes to see you that I have pain in my knee. You examine the joint, okay? So if there is pain on active or passive movement of the knee, if there is pain on active or passive movement of the knee, that indicates the patient has in fact knee pathology, okay? Patient comes to you that I have pain in my knee or I have pain in my elbow. So if you have to examine the patient, you have to examine that joint, and if there is pain on active or passive movement of the joint, that indicates the patient in fact has knee pathology or elbow pathology, whatever, okay? But if there is no pain on active or passive movement of that joint, okay, so the patient has suppose knee pain or elbow pain, and you move the knee of the patient, or move the this elbow of the patient or hip of the patient, whatever, okay? And if there is no pain, then it means that the pathology does not lie with the joint, okay? The joint is normal, and there is involvement of the periarticular structures like ligaments, tendons, or bursa, okay? This thing is important, okay? Patient comes to you with the knee pain, okay? You examine the knee, you move the knee, means flex or extend the knee. The patient says, I don't have any pain. So that means the pathology does not lie with the knee joint, okay? There is maybe there is something, there is a involvement of some other joint, okay? So also this thing is important, like sometimes osteoarthritis of the hip joint, osteoarthritis of the hip joint can lead to pain in the knee, means pain on the medial aspect of the knee, okay? So in fact the patient has osteoarthritis of the hip joint, and the patient has hip pain, but mild hip pain, okay, because of osteoarthritis, but the pain may be referred to the knee joint, okay? So the patient will report to you that I have pain in my knee, but in fact the knee is normal. And how will we come to know? Because by passive and active movement of the knee joint, okay? So this thing is important, okay? And if on movement of the knee joint there is pain, okay, so that means the pathology lies with the knee itself, okay? So with this knowledge in mind, we start with rheumatoid arthritis, okay? So this is, as you can see, this is a normal joint, and this is a rheumatoid arthritis. This is the normal joint, this is the rheumatoid arthritis. So you can see this the tendon, the synovial membrane, and the fluid, okay? And this is the joint capsule, okay? And in case of rheumatoid arthritis, there is inflammation of the synovial membrane, okay? So as you can see, there is a swollen synovial membrane, okay? So that's why there is secretion of lot of fluid in case of rheumatoid arthritis, okay? So the patient comes to you that I have pain in my joints. So in case of rheumatoid arthritis, as we know, there is symmetrical joint involvement, okay? So the patient will say, I have pain in both the knee joints, or I have pain in both the wrist or my metacarpophalangeal joints, whatever, okay? And they remain stiff for more than 1 hour, okay? So these things indicated the patient may have rheumatoid arthritis, okay? So what are the diagnostic criteria of rheumatoid arthritis? This thing is very important. So you don't have to write anything, everything is given in the notes. So diagnostic criteria of rheumatoid arthritis, it is first is a morning stiffness for more than 1 hour. Patient wakes up in the morning, the patient says, my joints are stiff, and after some movement, there is a relief of this stiffness, okay? So the stiffness means after 15-20 minutes, there is relief and stiffness. So that cannot be rheumatoid arthritis, because in rheumatoid arthritis, the stiffness has to be present for at least 1 hour, okay? The stiffness, morning stiffness for more than 1 hour, okay? And also, like, it has to be present for more than 6 weeks. Okay, so this 6 weeks is important. Patient has morning stiffness for more than 1 hour, okay? 15-20 minutes, that is not rheumatoid arthritis, okay? Morning stiffness is present for more than 1 hour, and it is present for more than 6 weeks, okay? It is present for more than 6 weeks. So this 6 weeks is important. Patient comes to you that I have stiffness from the last few weeks, 1 or 2 weeks, or from the last 1 month. It cannot be rheumatoid arthritis, okay? So these symptoms have to be present for at least 6 weeks to fit into the criteria of rheumatoid arthritis, okay? So this is the first criteria: morning stiffness for more than 1 hour for more than 6 weeks, okay? Swelling of the wrist, MCP joint, metacarpophalangeal joint, and PIP joint, for more than 6 weeks. Everything is given in the notes. You don't have to write. So swelling of the wrist, MCP and PIP for again more than, so swelling. So one is morning stiffness. Okay. Other is swelling of MCP joint, metacarpophalangeal joint, or we have wrist joint or proximal interphalangeal joint for more than 6 weeks. So this is another diagnostic criteria. Okay. Okay. So this is another diagnostic criteria. Swelling of the wrist, MCP and PIP for more than 6 weeks. And also the joints have soft tissue. So swelling, morning stiffness. Third is the joints have soft tissue swelling or fluid as observed by the physician for more than 6 weeks. So third criteria is soft tissue swelling or fluid as observed by the physician for more than 6 weeks. Okay. So this, as you can see in all the points, this 6 weeks is coming. Okay. So this is the third criteria, and fourth criteria is symmetrical joint involvement, like both the wrist, both the elbows, both the knees, both the hip joints, both the metacarpophalangeal joints. Okay, for more than 6 weeks. Okay. So again 6 weeks. So morning stiffness, swelling, presence of fluid. Okay. And we have symmetrical joint involvement, symmetry, again for more than 6 weeks. Okay. So that's so these are the four criteria, basic criteria, which have to be present to make a diagnosis of rheumatoid arthritis. There can be other criteria include like the presence of rheumatoid nodules, okay, positive rheumatoid factor, erosive synovitis on X-ray, periarticular osteopenia. So these things are there. Okay. So as I said, to make a diagnosis of rheumatoid arthritis, these four criteria have to be present, and they have to be present for at least 6 weeks. Okay. So patient comes to you with rheumatoid arthritis. What is the first thing you will do? Can you tell me? You suspect the patient has rheumatoid arthritis. What is the first thing you will do? Okay. So whenever you suspect that the patient has rheumatoid arthritis, okay, first step means that you will physically examine the patient. There is presence of there is a swelling, okay, there is stiffness, there is symmetrical joint involvement. So the first step is you will check rheumatoid factor. Rheumatoid factor. You will take the X-ray, okay, and you give the patient NSAIDs like ibuprofen or diclofenac, okay, naproxen, anything can be given. So NSAIDs for because NSAIDs they are anti-inflammatory, okay. Plus you give the patient steroids. Okay, these are the things you will do. You check the rheumatoid factor and you check the X-ray. Means you do X-ray means an X-ray will show periarticular osteopenia, and you give the patient NSAIDs, pain relief, and also you give the patient steroids. Okay, so means the NSAIDs are given because they're anti-inflammatory, and steroids are also given because they reduce the inflammation. Okay, so this is these are the things which you have done. Okay, and you send the patient home. So this rheumatoid factor also, always remember, it is negative in 20% of the patients with rheumatoid arthritis. Okay, the patient has rheumatoid arthritis, but still this rheumatoid factor can be negative. So you may see in this some of the questions like patient has rheumatoid factor negative, but still the patient has rheumatoid arthritis. Okay, so this is also important. So if patient has negative rheumatoid factor, then like negative rheumatoid factor, the next step is we go for anti-CCP antibodies. Okay, so this is the like negative rheumatoid factor, then the anti-CCP antibodies, which are highly specific for rheumatoid arthritis. Okay, so this rheumatoid factor may be positive in other diseases also. This may be positive in SLE, may be positive in Sjogren's syndrome, may be positive in systemic sclerosis. Okay, but these anti-CCP antibodies, they are positive only in case of rheumatoid arthritis. Okay, and so we have negative rheumatoid factor, but still means we know that the patient has rheumatoid arthritis. We may do anti-CCP antibodies, and presence of anti-CCP antibodies means patient has poor prognosis. The patient has advanced disease, poor prognosis. Okay, these things you have to remember. Okay, X-ray will show this swelling, and there is a narrowing of the joint. X-ray will show narrowing of the joint space, periarticular osteopenia, and destruction of the cartilage. Okay, periarticular osteopenia, destruction of the cartilage, and narrowing of the joint space. So this thing is important. So also there will be high ESR, means non-specific things. Okay. So rheumatoid arthritis, it's basically an autoimmune disease. It's a T cell mediated injury. So there will be infiltration of the joints with T lymphocytes. So this is also one of the question in few in one of the NBMEs. So rheumatoid arthritis, it is a T cell mediated injury. So there will be infiltration of the joints with T lymphocytes. So if the patient has HIV, if the patient has HIV, okay, there is patient is HIV. Okay, so in HIV infection, there is a relief of there is a it's an autoimmune disease, and there is deficiency of T lymphocytes. Okay, so because of the deficiency of T lymphocytes, if the patient becomes HIV positive, okay, there is relief in symptoms of rheumatoid arthritis. Okay, relief in symptoms of rheumatoid arthritis. Okay, so this thing also is important. It's a question in a few of the NBMEs and also in the QBACs. Okay, it's a T cell mediated injury. Okay. Another important point is rheumatoid arthritis never involves the axial skeleton. Okay, I have seen very advanced cases of rheumatoid arthritis. Okay, there is destruction of the fingers. I will come to that. And the patient says, like, I feel pain in my neck. Okay, but there is there is never involvement of the axial skeleton except the cervical spine. Okay, so the pain in the neck means there is involvement of the cervical spine. Okay, clear. So this is the advanced case of rheumatoid arthritis. You can see the Bottom's deformity of the thumb, ulnar deviation of the metacarpophalangeal joints, swan neck deformity. So these are seen in very advanced cases of rheumatoid arthritis because of the destruction of the cartilage. As I said, the X-ray will show in the initial stages also there is periarticular osteopenia, reduction of the joint space, and destruction of the cartilage. So because of the destruction of cartilage, in advanced cases there will be these deformities will occur. Okay, and it does not involve the spine except the C1 and the C2 vertebrae. So rheumatoid arthritis never involve the axial spine, okay, axial skeleton except the C1 and the C2 vertebrae, causing the so the patient will have neck pain, hyperreflexia, and neck stiffness. Okay, so it will cause subluxation of the atlantoaxial joint. Okay, so this is what happens when there is involvement of the C1 and the C2 vertebrae. Okay, so this is the C1 and the C2 vertebrae. So there is forward slippage of the vertebrae because there is involvement of these vertebrae, so it will lead to cord compression. Okay, so neck pain, hyperreflexia, and neck stiffness. Okay, so it causes subluxation of the atlantoaxial joint. Okay, so whenever you are intubating the patient, suppose the patient has motor vehicle accident, severe MVA, and the patient is lying on the floor and unconscious, you will intubate the patient. So whenever you intubate the patient, you have to hyperextend the neck. You have to hyperextend the neck. Okay, so you have to make sure that the patient does not have advanced case of rheumatoid arthritis. Okay, if you hyperextend the neck, it can lead to cord compression. Okay, if the patient has in fact advanced case of rheumatoid arthritis. Okay, so whenever you are intubating any patient, suppose the patient is in the emergency room or in the operating room. Okay, you are intubating the patient, and you have to make sure that the patient does not have rheumatoid arthritis. Otherwise, it will lead to advanced case of rheumatoid arthritis. Otherwise, it will lead to cord compression. Okay, now there is something called bulge sign in case of rheumatoid arthritis. So this is the bulge sign, as you can see. So there is inflammation of the synovium. As I said, there is inflammation of the synovial membrane in case of rheumatoid arthritis. So that will cause excessive fluid secretion. Okay. So like you palpate the knee joint. Okay, and so there is a fluid here, excessive amount of fluid here. Okay, here like okay. So you palpate this joint and means that you press. Okay, so the fluid will move toward this side. Okay, so this will be seen means that this will be seen as a bulge. Okay, so this is bulge sign. Okay, because of excessive secretion of the fluid. Also, there is proliferation of the synovial membrane causing pannus formation. So this pannus formation is also important. There is proliferation of the synovial membrane causing pannus formation. So this pannus, it will destroy the cartilage, it will destroy the bones, tendons, the ligaments. Okay, this thing also is important. Okay, so you made a diagnosis of rheumatoid arthritis, as I said earlier also, and okay, so this is sorry, this is pannus formation. There is proliferation of the synovium. So see the excessive, huge proliferation of the synovium. Okay, so this is the normal synovial membrane, and you can see the pannus formation. So wherever you find that the pictures are important, you can take screenshot. Okay, this is pannus. Okay, so this will cause destruction of the cartilage, bones, tendons, and the ligaments. Okay, so this is pannus formation. Okay. Okay, so we start treating the patient. Uh, the patient has this rheumatoid arthritis. So the first step I told, we take X-ray, we take rheumatoid factor that can be negative. X-ray will show narrowing of the joint space, periarticular osteopenia, destruction of the cartilage. Okay. So we give the patient ibuprofen, NSAIDs, and steroids. So whenever the diagnosis of rheumatoid arthritis has been made, we have to start the patient on DMRDs, disease modifying anti-rheumatic drugs. We have to start the patient on DMRDs. Okay. And they have to be started within 3 months of diagnosis of rheumatoid arthritis. This is very important. Earlier in means earlier very in past the protocol was like the patient has very advanced case of rheumatoid arthritis, then we used to start this DMRDs. Okay, now we have to start this disease modifying anti-rheumatic drugs within 3 months of diagnosis of rheumatoid arthritis, even if the patient has is a mild case of rheumatoid arthritis. Okay, so they delay the progression of the disease. NSAIDs are anti-inflammatory. Steroids will also reduce the inflammation, but they will not delay the progression of the disease. Only agents which will reduce the progression of the disease is DMRDs. Okay, disease modifying anti-rheumatic drugs. So we can give the patient sulfasalazine. Okay, and hydroxychloroquine. So various DMRDs, it's everything is given in the notes. Like we have sulfasalazine, hydroxychloroquine, TNF alpha antagonist. So if the patient has mild disease, very mild rheumatoid arthritis, so we start the patient on sulfasalazine. Okay, and if the patient has slightly advanced disease, then we give the patient methotrexate. Methotrexate, which is a dihydrofolate reductase inhibitor, and it causes decreased utilization of folic acid. So it will prevent the methotrexate. It will prevent the utilization of folic acid. So that will give the rise to deficiency of folic acid. So that's why whenever we have give the patient methotrexate, we give the patient folinic acid. We give the patient folinic acid. Okay. So so there is deficiency of folic acid. So give the patient folinic acid. Okay. So this methotrexate causes bone marrow suppression and leading to pancytopenia, and also it is hepatotoxic causing high AST ALT. So these uh, side effects of methotrexate are very important. It is hepatotoxic causing high AST ALT. It causes suppression of the bone marrow causing pancytopenia, and also there is a decreased utilization of folic acid. So we have to give the patient folinic acid. Okay. So whenever we give methotrexate to the patient, we have to monitor both CBC and LFT. Both CBC and LFT. Okay, so CBC, why? Because it causes pancytopenia, and LFT, why? Because it is hepatotoxic. Okay, so we cannot give methotrexate when the patient is alcoholic or the patient has hepatitis. Okay, because it's contraindicated. Okay, also it causes alopecia, oral ulcers, interstitial lung disease, and also it is teratogenic. Okay, everything is given in the notes. Okay, so you don't have to write. These are the side effects. Any other drug which you can think of in which we monitor both CBC and LFT? Can you tell me? So, in when we give the when we give methotrexate to the patient, we monitor both CBC and LFT. Any other drug which you can think of in which we monitor both CBC and LFT? Can you tell me? So, both CBC and LFT it is monitored in case of carbamazepine,
Mhm.
because it causes also causes bone marrow suppression. It causes also causes liver damage. Carbamazepine, and also in case of interferon.
Okay.
These drugs are when we are giving, we monitor both CBC and LFT. Okay, we monitor CBC when we give the patient clozapine because it causes agranulocytopenia. Okay, LFT we monitor when we give the patient statins. Okay, but both CBC and LFT it is monitored when we give the patient carbamazepine, methotrexate, interferon.
Okay.
Okay, so if the patient is pregnant, as I said, methotrexate it is contraindicated, so it is teratogenic. So we give the patient sulfasalazine or hydroxychloroquine. This is also very important. You are giving the patient methotrexate. Suppose the patient has rheumatoid arthritis, and she's your patient in the last few months, and you are giving the patient methotrexate. And one day she comes to you that I'm very excited, doctor. I'm pregnant. So that means the you have to stop methotrexate because it's teratogenic, and you will give the patient either hydroxychloroquine or sulfasalazine. So hydroxychloroquine or sulfasalazine it is used if the patient is pregnant. Okay? So because they are not teratogenic. So okay, that's for pregnancy, sulfasalazine or hydroxychloroquine. Now if we are giving the patient methotrexate from the last few months and still there is no relief, we give the patient TNF alpha antagonist. Okay, TNF alpha antagonist. These are also important. TNF alpha antagonists like etanercept, infliximab, and leflunomide. Okay, so these are given in case of rheumatoid arthritis when methotrexate is not effective. TNF alpha antagonist, and also they are used in case of Crohn's disease. We use TNF alpha antagonist. Okay, so rheumatoid arthritis when methotrexate is not effective. In case of Crohn's disease, we use TNF alpha antagonist. Any other condition you can think of in which we use TNF alpha antagonist? So they are also used in case of seronegative spondyloarthropathies like ankylosing spondylitis, or the patient has reactive arthritis, psoriatic arthritis, enteropathic arthritis. Okay, so in seronegative spondyloarthropathies also we give the patient TNF alpha antagonist. Okay, so before starting TNF alpha antagonist, we will go for PPD. We go for PPD testing, and if PPD is more than 10 millimeter, then we just give the patient isoniazid and pyridoxine for 9 months. So if so we go for PPD, and because we want to rule out because when we give the patient TNF alpha antagonist, there is higher risk of TB infection. So we go for PPD, and if it is found to be more than 10 millimeter, we give the patient isoniazid and pyridoxine for 9 months. Okay, so that's the treatment protocol for rheumatoid arthritis. First step is always do X-ray, rheumatoid factor, which may be negative in some of the cases. Give the patient NSAIDs, steroids, and also DMRDs. Okay, and DMRDs have to be started within 3 months of diagnosis. So we start with mild cases, sulfasalazine or hydroxychloroquine are also in pregnancy, and in slightly advanced cases, we can give methotrexate. And if methotrexate is not effective, we give the patient TNF alpha antagonist. Okay, and before starting them, we rule out PPD. Okay, PPD. Okay. Now, there are some extra articular manifestations of rheumatoid arthritis. These questions are also being asked these days. So, as you can see, these are extra articular manifestations of rheumatoid arthritis. So it can lead to lymphadenopathy, pericarditis, bursitis, okay, splenomegaly, that is Felty syndrome. This thing we know. So, rheumatoid arthritis plus splenomegaly plus granulocytopenia, that is Felty syndrome. Okay. Also, the patient can have a Kaplan syndrome. So Kaplan was a physician. This is a topic of respiratory. So Kaplan was a physician who found that if the patient has rheumatoid arthritis, patients who had rheumatoid arthritis and who were working in coal mines, they had rheumatoid nodules in the periphery of the lung. They had rheumatoid nodules in the periphery of the lungs. Okay, so keratoconjunctivitis can occur, amyloidosis, neuropathy, peripheral neuropathy, like we have carpal tunnel syndrome. Okay, tendon sheath swelling. So these are the various extra-articular manifestations of rheumatoid arthritis. So these extra-articular manifestations of rheumatoid arthritis, okay, so these indicate that the patient has a very aggressive disease, okay, like patient will have rheumatoid nodules also, rheumatoid nodules, like we have, so these are rheumatoid nodules, as you can see, these are rheumatoid nodules. Okay, so these are there will be high, means the patient will have rheumatoid nodules, extra articular manifestations, a very high amount of rheumatoid, high titers of rheumatoid factor. Okay, and also anti-CCP antibodies positive. So all these indicate that the patient has very advanced disease. Okay, so anti-CCP antibodies, rheumatoid nodules, extra articular manifestations, extra articular manifestations. Okay, and also extra articular manifestations, and also the patient will have high titers of rheumatoid factor, very high amount of rheumatoid factor. Okay, antibody. Okay, so that's indicate highly aggressive disease. The most common, so another thing is like rheumatoid arthritis causes excessive fluid secretion, and this fluid may enter the popliteal space, causing Baker's cyst. So this is also a question. Baker's cyst. So this is Baker's cyst. Sorry, this is Baker's cyst. So there is a, as is, there is excessive fluid secretion because of the inflammation of synovial membrane. So this fluid may enter the popliteal space, causing Baker's cyst. Okay. So rupture of this Baker's cyst causes liberation of the contents into the leg, causing swollen limb, resembling DVT. Okay. And rheumatoid arthritis, so this will like, it will, rupture of the Baker's cyst causes swelling of the leg. Okay. It will means it will look like that the patient has DVT. Okay. And also, the rheumatoid arthritis patients are at increased risk of, this is also a question for a few of the Q banks, and also in NBM is an assessment test. Rheumatoid arthritis patients, they are at increased risk of osteopenia and osteoporosis, and also septic arthritis. So osteopenia, they are at increased risk of osteopenia, osteoporosis, increased risk of osteopenia, osteoporosis, also septic arthritis. Okay. And the most common cause of death in case of rheumatoid arthritis, it is coronary artery disease. Because rheumatoid arthritis, it's a inflammatory disease. It is an inflammatory disease, okay? And because of this inflammation, there will be atherosclerosis, as this is a coronary blood vessel. Suppose there is inflammation, so that will lead to atherosclerosis, formation of plaque, okay, like this, okay. So that will lead to death of the patient. Okay, so the most common cause of death in rheumatoid arthritis, it is coronary artery disease, okay, due to inflammation. Okay, so that's for rheumatoid arthritis. Okay, any questions you want to ask? Most every points are given in the notes, so you don't have to write anything. Okay. Clear? Any questions? So this is a Felty syndrome. There is a pneumonic centa, splenomegaly. There is a rheumatoid arthritis, and also the patient will have granulocytopenia. Other features may be present, okay, in Felty syndrome, like thrombocytopenia, okay, anemia. This way you can remember. Clear? Okay, next is a juvenile rheumatoid arthritis. So that's for rheumatoid arthritis. Next is a juvenile rheumatoid arthritis, okay, JRA. So there are three main types of JRA. Three main types of juvenile rheumatoid arthritis, okay. So one is polyarticular, postearticular, and systemic, also known as oligoarticular. So whenever there is oligoarticular means three or four joints. So this is also important in rheumatology. Means that whenever you see a joint, like the patient has psoriatic arthritis, I will come to those things, or the patient has reactive arthritis. So, and we say that the patient has oligoarticular joint involvement. That means three or four joints. Means four or less than four joints. And polyarticular means five or more joints. Okay, this thing also you can remember. So we have juvenile rheumatoid arthritis. It is divided into oligoarticular, polyarticular, and systemic. So systemic juvenile rheumatoid arthritis, it is also called Still's disease. Okay, so this systemic, it is also called Still's disease. It is also called Still's disease. Okay, and if the patient is more than 16 years of age, then it is called adult Still's disease, adult onset Still's disease. Okay, so this rheumatoid factor, it is negative in case of Still's disease. Rheumatoid factor, it is negative. So as in most of the cases of rheumatoid arthritis, it was positive, but here it is negative. Okay, in case of Still's disease. So how will you diagnose Still's disease? Means what are the criteria? Can you tell me? Okay, so this is the criteria for Still's disease. So we have major criteria. Still's disease, as I said, it is adult onset. Means it is systemic juvenile rheumatoid arthritis. So we have the major criteria and minor criteria. These things you have to remember. So patient will have fever more than 39 degrees centigrade for more than 1 week, arthralgia or arthritis, okay, typical rash. So this rash, it is evanescent rash, means it appears and then it disappears. So it appears and disappears with the fever. Patient has high fever, the rash will appear. Patient, the fever subsides, or the patient has low fever, the rash will disappear. Okay, so this is highly characteristic. And also the patient will have high WBC count, neutrophilia. Okay, these are the major criteria. And minor criteria are sore throat, lymphadenopathy, high LFTs. Okay, rheumatoid factor and ANA are negative. This thing I told earlier also. Okay, so this fever has a lot of variation. Means it varies a lot, more than 4 centigrade. Okay, and also the rash appears and disappears with this fever. Okay, so this is evanescent rash. So this evanescent means the rash appears and disappears with this fever. So this is called evanescent rash. Means it appears and then it disappears. So this evanescent rash, it is also seen in case of urticaria, in which there is a appearance of the rash and then it disappears. Okay, and there is something called sixth disease or rosula infantum. In this sixth disease or rosula infantum, what we will have is like the patient has high fever, and then fever subsides. Patient has high fever and then fever subsides, fever disappears, and then rash appears on the trunk, and then it moves to the extremities. Okay, so there is high fever, fever subsides, and then rash appears on the trunk and then the extremities. Okay, in case of Still's disease, the rash appears and disappears with the fever. That's for Still's disease, adult onset Still's disease. Okay, AOST, adult onset Still's disease. Okay. Clear? Any questions? and this is the rash which occurs in case of Still's disease. This kind of rash. Okay. Okay. Next is a SLE. So SLE. So always like there are diagnostic criteria of SLE. As you can see, there is a criteria for diagnosis of SLE. It's a huge criteria. I will explain. So a simple way to learn about SLE, systemic lupus erythematosus. It is any young patient with fever, arthralgia, rash, and pruritic chest pain. It is SLE. Fever, arthralgia, rash, and pruritic chest pain. It is SLE. Okay. And diagnostic criteria for SLE, it is given. So it is dopamine rash. You can remember it by dopamine rash. This mnemonic. This is my mnemonic. Make your own dopamine rash. Okay. So D for disc-shaped rash. Disc-shaped rash. Okay. O for oral ulcers. P for photosensitivity. Okay. A for arthritis. So this arthritis of SLE, it is migratory arthritis. It is non-erosive. Means in case of rheumatoid arthritis, we had erosive arthritis. Means there was damage to the, as I said, there was damage to the significant damage to the cartilage. In case of SLE, SLE, it is non-erosive. So this ACR, it is American College of Rheumatologists. American College of Rheumatologists. Okay. So we have so coming back to the diagnostic criteria. So we have disc-shaped rash, oral ulcers, photosensitivity. A for arthritis. So arthritis is non-erosive and it is migratory. Okay. Means in case of rheumatoid arthritis, it was erosive. Okay. Here it is migratory and non-erosive. There is no destruction of the cartilage. There is no significant destruction of the cartilage. So this migratory arthralgia or arthritis, it is seen in a lot of other conditions also, like the patient has rheumatic fever, or the patient has Whipple's disease. In case of SLE, in case of DGI, disseminated gonococcal infection, in case of Lyme disease. So we have a lot of conditions in which we have migratory arthralgia or arthritis, like SLE, migratory arthralgia, Whipple's disease, Lyme disease. So these things you can note down: Lyme, SLE, Whipple's disease, Lyme disease. We have mm, rheumatoid, rheumatic fever, that is also migratory, and that's it. DGI, disseminated gonococcal infection, like the patient has urethritis or the patient has cervicitis caused by gonococcal. Okay, so gonococcus. Okay, so this is not treated. The infection can spread and can lead to DGI, which is a patient has hemorrhagic pustules, and also the patient has arthralgia and tenosynovitis. Okay, arthritis or tenosynovitis. Okay, so that's it. It's a triad. I will come to that. Okay, so these cases we have migratory arthralgia. Okay, so coming back to or arthritis. So coming back to dopamine rash. So we have disc-shaped, discoid rash. I will explain everything. Okay, oral ulcers, photosensitivity, arthralgia, which is migratory. Okay, and there is no significant damage to the cartilage. Okay, Malar rash is present on the cheeks and nasal bridge, but it spares the nasolabial fold. So that is Malar rash. Butterfly like rash, which spares the nasolabial fold. Okay, and we have I for immunological abnormality, like the patient has Immunological abnormality, like the patient has positive ANA, positive anti-double stranded DNA, positive anti-Smith antibodies, okay, and false positive serological test for syphilis, like VDRL may be positive, VDRL can be positive, okay. So these things can be seen. So we have a I for immunological disorder, and for neurological abnormalities, like the patient has seizures, and for neurological abnormality, like the patient has seizures, okay, psychosis, okay, and R for renal abnormality. This R for renal abnormality. So there is proteinuria, as we know. Patient will have a nephritic syndrome. So this SLE causes nephritic syndrome. There is proteinuria. There is hematuria. Okay, and also so A for ANA, R for renal abnormality, A for positive ANA, anti-nuclear antibody. This is the criteria. Okay, and as for serositis, serositis is there is inflammation of the pleural membrane causing pleurisy or pericarditis. So as for serositis, okay. So there are a lot of criteria. So I told H and H for hematological abnormality. Okay, so like the patient has hemolytic anemia, leukopenia. Okay, so anemia in case of SLE, this is also an important question. It is normocytic normochromic anemia. Normocytic normochromic in case of SLE. So there is a lot of means. If you look at these criteria, they look complicated. So this is a simple way to remember dopamine rash. Okay, so all these cases. Okay, so we take up one by one. So we have disc shaped rash. You can remember follicle plugging with scarring. This you can remember. Okay, oral ulcers. So always remember, SLE it is the only disease generally in which the patient has painless oral ulcers. Painless oral ulcers. What are the other causes of ulcers? Oral ulcers. Can you tell me? There are huge causes of oral ulcers. Like patient has SLE, patient has herpes, patient has which is also painful, or the patient has abscess ulcers, Coxsackie A virus causes ulcers, abscess ulcers, okay, herpes, SLE, or drugs. There are some drugs which can cause oral ulcers, okay, like I said, methotrexate, and the Candida infection can also cause ulcers. Behcet syndrome that also causes oral ulcers, okay, and Crohn's disease also causes oral ulcers. So there are a lot of diseases in which we have oral ulcers, okay. But characteristic feature of SLE it is painless ulcers. So whenever you in a question you see painless ulcers, oral ulcers, that is SLE, okay. So we have discoid rash, oral ulcers which are painless. P for photosensitivity, A for arthritis which is non-erosive and migratory, and M for malar rash. So this is also important. A butterfly-like rash which spares the nasolabial fold. This is very important. I will come to that. I will explain this. Okay. Uh, then we have I for immunological abnormality, and for neurological, E for we have sorry, E for raised ESR, R for renal abnormality, ANA, then hematological abnormality. So these are criteria. Okay. So this is the butterfly rash. So we have discussed the criteria. So this is the butterfly rash. Okay, as you can see. So it is sparing the nasolabial fold. This is the nasolabial fold. Okay. So this is characteristic of SLE. It spares the nasolabial fold. Okay. In case of rosacea and in case of seborrheic dermatitis, the rash it involves the nasolabial fold. Rosacea and in case of seborrheic dermatitis, it involves the nasolabial fold. This thing will be involved. Okay. This point is also important. Okay. This is very important. So rosacea and seborrheic dermatitis, they involve the nasolabial fold, and SLE spares the nasolabial fold. Okay, so seborrheic dermatitis occurs in areas where there is excessive sebum production. Now, if the patient has excessive seborrheic dermatitis, what is seborrheic dermatitis? Basically, it's dandruff, severe form of dandruff. Okay, so if the patient has excessive amount of seborrheic dermatitis, what is the first thing you will do? What is the test you will do? Can you tell me? What is the test you will do when the patient has excessive amount of seborrheic dermatitis? So, seborrheic dermatitis and rosacea. Sorry, in case of extensive amount of seborrheic dermatitis, we have to rule out two diseases which are SLE and which is Parkinsonism and HIV. Parkinsonism and HIV, because in these two diseases there is extensive amount of seborrheic dermatitis. Okay. Okay. Okay, next is so the patient comes with this diagnostic criteria which I told. So presence of four or more diagnostic criteria, presence of four or more of these diagnostic criteria, dopamine rash. Okay, so then it makes a diagnosis of SLE. If the patient has four or more of these diagnostic criteria, it makes a diagnosis of SLE. So once a diagnosis of SLE has been made, so what is the next thing you will do? So next thing, as in rheumatoid arthritis, we'll go for X-ray and we go for ANA test. Okay, and we give the patient steroids, ibuprofen, and also hydroxychloroquine. So the patient has a pain, so we give the patient this ibuprofen and steroids to reduce the inflammation. X-ray we will do, okay, and we go for this ANA test, and also we give the patient hydroxychloroquine. Okay, so this is these are the drugs which we give the patient in case of SLE. And if the patient, when we give the patient hydroxychloroquine, this thing also you have to remember, we will go for periodic eye examination, because hydroxychloroquine damages the eyes, can damage the eyes, so we have to go for periodic eye examination. These are the various antibodies. ANA is positive in more than 95% of the cases of SLE, but it can be negative in also. Okay, and this ANA is positive in the general population also. Like the patient comes to you, suppose any patient, and you check the ANA, it comes out to be positive. That does not mean the patient has SLE or the patient has this Sjogren's syndrome or systemic sclerosis. ANA is positive in 10 to 15% of the general population also. Okay, so we have to do ANA, anti-nuclear antibody, only if the patient has like clinical relevance. Okay. So once ANA is positive, as I said, it is positive in most of the cases, then we go for specific test. Then we go for specific test, anti-double stranded DNA, which is specific for SLE, anti-Smith antibodies, anti-Rho, anti-La antibodies, okay, but they are not very disease specific. Anti-ribonucleoproteins, it is also not very specific. Anti-phospholipid antibodies, okay, so these are associated with SLE. I will come to that. Okay, so they have excessive. The patient will have excessive fetal loss and also recurrent thrombosis, recurrent arterial and venous thrombosis. Okay, recurrent arterial and venous thrombosis plus recurrent fetal loss. Can you tell Can you tell me what are the causes of both arterial and venous thrombosis? So one of the cause of both arterial and venous thrombosis, it is antiphospholipid antibody syndrome. Okay. Any other cause of both arterial and venous thrombosis you can think of? Okay, so the cause of both arterial and venous thrombosis, it is antiphospholipid antibody syndrome, factor 5 Leiden, factor 5, the Leiden variety of factor 5, protein C deficiency, protein S deficiency, okay, and homocystinuria, that also causes both arterial and venous thrombosis. And we have mm, uh, polycythemia rubra vera, okay, and heparin-induced thrombocytopenia that also causes both arterial and venous thrombosis. So these are the causes. The details means this is a topic of hematology. Okay, so these are the various causes of both arterial and venous thrombosis, and antiphospholipid antibody syndrome. It is one of these. Okay. So as I said, this SLE causes, it's an important cause of nephritis. It's a nephritic syndrome. Okay, so there is various classes: class 1, class 2, class 3, class 4, class 5. Okay, so or type 1. So type 1 it is normal generally. Type 2 it is a mesangial, which is a there is mesangial proliferation. Okay, type 3 it is a focal proliferative. So there is epithelial cell proliferation. So that is focal proliferative. Type 4 it is diffuse proliferative. Okay. So this diffuse proliferative, it is the most common and the most severe form of glomerulonephritis. If you're asked what is the most common renal abnormality in case of SLE, it is type 4, which is diffuse proliferative. This one. Okay. This is diffuse proliferative. Most common and most severe form of glomerulonephritis. And type 5, it is membranous. So generally, this SLE causes nephrotic syndrome. Sorry, nephritic syndrome. But class 5, type 5, it causes, it is a cause of nephrotic syndrome. Rest these are nephritic. Clear? And there is type 6 also, which is there is fibrosis. Okay, so these are the various kidney manifestations, and the most common it is class 4, membrano proliferative, sorry, diffuse proliferative. So why kidney dysfunction occurs? As I said, there are anti-double stranded DNA, means there is an antigen antibody complex. Actually it is a type 3 hypersensitivity reaction. So there is antigen antibody complex formation, and these complexes, these get deposited in the kidneys. So there is these complexes, they are very large. So there is subendothelial deposits. Okay, so this is the endothelium, and this is the basement membrane, this is the epithelium. Okay, endothelium, basement membrane, and then the epithelium. Okay, so there is subendothelial deposits here, as you can see, subendothelial deposit. Okay, so they are not able to cross the basement membrane. Okay, in case of post streptococcal glomerulonephritis, we have subepithelial deposits. I will cover the details in nephrology. Okay, so in SLE we have subendothelial deposits. In post streptococcal glomerulonephritis we have subepithelial deposits. This thing also are important. Okay, because these are large complexes, they will not be able to pass the basement membrane. In post streptococcal glomerulonephritis, these are smaller complexes, they will be able to pass through the basement membrane easily. Okay. Okay, so we come back to the treatment. We diagnose the patient as SLE because four or more than four criteria they are present. Dopamine rash, and we give the patient hydroxychloroquine. We did X-rays. We give the patient steroids and ibuprofen, and we go for periodic eye examination, as it is hydroxychloroquine can cause damage to the eyes. Now, if the patient has severe disease, like there is involvement of the kidneys or involvement of the CNS, as I said, there can be nephritis, there can be renal abnormality, or there can be neurological abnormality. Okay, so if the patient has major organ involvement, then always remember this point. Then we have to give the combination of cyclophosphamide plus high dose steroids. Cyclophosphamide and high dose steroids. Okay, high dose steroids. Okay, whenever the patient has major organ involvement. So this is the rule, not in case of SLE, but also in any case, like the patient has polyarthritis nodules. I will come to that later, in which there is a GI involvement, or the patient has a Churg-Strauss syndrome, in which there is a major organ involvement, like renal involvement or neurological involvement. So we have to give the combination of cyclophosphamide plus high dose steroid. So this is the treatment for SLE. So generally hydroxychloroquine, but hydrosteroids plus cyclophosphamide in case of major organ involvement. So as there is antigen antibody complexes, this thing I told, and these antigen antibody complexes, they get deposited in various organs, causing damage. Okay, and so they cause activation of the complement. So there will be decreased complement in case of SLE. C3 level is decreased. Okay, there is decreased C3 level, and also uh, increased anti-double stranded anti-DNA, anti-double stranded DNA. Okay, so this anti-double stranded DNA and C3, they are used to monitor response to therapy. Okay, so if the patient has very severe disease, very severe disease, so in that case, the patient will have decreased C3 level and very high amount of double stranded DNA. Okay, this is also a question. So these two tests are done. Once we have started the treatment, we will go for periodic checkup of these two tests, and these are used for to monitor response to therapy. Okay. Okay, now you are treating the patient. Okay, you are checking the C3 level, you are checking the anti-double stranded DNA. So one day the patient comes to you, doctor, I'm very excited, I'm pregnant. Okay, so in case of pregnancy, you should screen for anti-Rho antibodies. Anti-Rho antibodies, okay, SSA. They are not present in Sjogren's syndrome, they can be present in SLE also. So if the patient with lupus becomes pregnant, you have to check these anti-Rho antibodies, okay? And if they are positive, if they are positive, that means if they are positive, that means the patient has the like advanced disease. So these antibodies, anti-Rho antibodies, they can cross the placenta. They can cross the placenta and they can damage the fetal heart, causing fetal heart block. So this is very important point. Fetal heart block. Okay, so if these antibodies are positive, we will go for fetal echo. So if the patient is pregnant, if you're asked what is the next thing you will do, we will check for anti-Rho antibodies. Okay, and if these antibodies are positive, if these antibodies are positive, we will go for fetal echo, because we have to rule out fetal heart block. Okay, so these antibodies can be positive in Sjogren's syndrome also. Okay, and also in case of SLE. So this is for SLE. Any questions? One thing also is important. Like I told, there is kidney manifestation, various renal manifestations. Okay, so we check the bun creatinine value. Patient has positive. Patient has excessive damage to the kidneys. Okay, patient has SLE and there is damage to the kidney, so we'll check for bun creatinine value. So this blood urea nitrogen creatinine value, and if this bun creatinine it is found to be high, if it is found to be high, then the next step is kidney biopsy. Biopsy of the kidneys. Okay, so we will know which disease the patient has. Means what is this means, because that high bun creatine value means the patient has kidney damage. So we want to know what is the class, what is the type of kidney damage, what is exactly happening in the kidney. Okay, so depending upon the this kidney involvement, we will give the patient treatment. That is, I told high dose steroids plus cyclophosphamide. Okay, so we want to know what is exactly happening in the kidneys. So when we do biopsy, we will come to know which class the kidney, which class the patient has, class 1, class 2, class 3, class 4, class 6. Okay, whatever. Okay, so this is the protocol. We check the bun creatine value, found to be high, we go for biopsy to rule out, to know the extent of kidney damage and also the class of kidney disease. Okay, and we will give the patient treatment accordingly. Okay. So in case of rheumatoid arthritis, I told coronary artery disease. Coronary artery disease, it is the most common cause of death in case of rheumatoid arthritis. In case of SLE, chronic renal failure. Chronic renal failure, it is the most common cause of death. Okay. That's for SLE. Any questions? Okay, next, what are the drugs which cause SLE? Can you tell me what are the drugs which can cause lupus? Can you tell me any idea?
I knew it. I forgot.